Okay. So again, we're going to be going over fluid and electrolytes. We're going to go over the outline. So again, this is going to require some participation for you guys. You can use the chat. Right now, it's open to everyone, like it used to be. But if you want to, you can still make it so that if you click two, you can still change it. If you only want to message me or Kaylin directly, otherwise you can have it to everyone. And at the end of this, you guys are going to get the PDF, and you guys are going to be able to use that for study material. Okay. All right. Cool. So let's just go over electrolytes. Again, your focus is still on sodium and potassium. So what is the normal value for sodium? Yeah, most likely you'll see 135. Sometimes maybe you'll see 136 to 145. Pretty common normal value for that. And while we're there, let's talk about the normal value for potassium. Okay, so make sure you always remember these. Great, 3.5 to 5. Okay. Between potassium and sodium, which one is more critical? Like if you see 5.1 of potassium, you're worried. If you see 146 of sodium, are you worried necessarily? Depends on the trends, of course, but when it comes to sodium, you guys have a little bit more wiggle room with sodium? Yeah, you have a little bit more wiggle room. The one you'll probably see the most in terms of considered a more critical value for sodium is, let's see, critical value. You'll probably see under 125. That's when people start having that risk of seizures, seizure risk, just general level, altered level of consciousness. You'll see patient with apparent neurological deficit. They'll look like they had a stroke almost, but it doesn't mean they had a stroke, but they might look similar. Just kind of their face, like just kind of like not there all the way, maybe drooping to one side. Um, so what kind of goes with that? So neurological deficits. Okay, just things to keep in mind um, for the future. So hypernatremia. What are some things you guys equate with hypernatremia? Thirsty, sure. So there's actually two types. So let's go over hyponatremia, hypervolemic, hyponatremia. That kind of applies to hyponatremia as well. So when you have hypernatremia, yeah, decrease in blood pressure with the hypovolemic. So yeah, it's kind of like a combination when you think about it. The hypovolemic also kind of talks about fluids. So fluids um, that can also include the decreased blood pressure because you have the hypovolemia, decreased blood pressure. So a lot of the time you're going to be thinking about basically the signs and symptoms of dehydration with hypovolemic, alongside some of the hypernatremic ones. So kind of goes along with that. So you'll have increased heart rate because again it's hypovolemic. So it's compensation, maybe some increased respiratory rate as well. But then for just a purely sodium-based one, it's going to be as you guys just mentioned thirsty. So what about sodium-specific stuff? And Kayla asked me, do you get nausea, vomiting, and sodium? That you can. Yeah, you can have that. So hypovolemic, you get the week 30 pulses. So right now we're doing good on our hypovolemic part. What about just the purely sodium part? So this is hypernatremia. So let's think about that. So yeah, muscle spasms. Usually think about like muscle twitching, muscle spasms, confusion. Yeah, altered level of consciousness also kind of goes with the hypovolemic part. Remember, this is still hypernatremia. We're hypovolemic, but we're hypernatremic. So what can this entail? Is could be like think about like a cup of salt water. You take away a lot of the water in there, and then you have all those salt particles floating around. It becomes more salty. You're basically salty because you have less water going on. Lethargic, sure. Another thing you might see stomach cramping. Yeah, with hypernatremia, you'll see like the nausea, vomiting, diarrhea even. Decreased urine output. With your hypervolemic, you'll probably have decreased urine output, yes, because you don't have enough fluid. Okay. Muscle weakness, yeah. Muscle weakness I think is a little bit more with the potassium ones, but your hypernatremia, hyponatremia, we have think about a little bit more like muscle twitching, muscle cramping. Um, you can have some weakness as well, but I think it's a little bit more associated with twitching. See, Anne had her hand up.
So when there's nausea and vomiting, is that considered increased motility? Is that what we call that?
Because it also comes with diarrhea. Yeah, I would say it's with you when you have hypernatremia, you end up having increased GI motility.
Okay, thank you.
Yeah. What about treatments? How do you treat having low water, high sodium? So we said salt restriction, definitely. Hypotonic solutions, that can be a way to try to treat it. With hypotonic solutions, you also got to think about how fast it causes fluid shifts. So, um, as well, but definitely that is a thing to take into account. Rehydration in general is going to be something that you're going to be doing. Salt restriction, rehydration, um, and stuff like that. I believe hypotonic does work as well. So hypotonic solutions, but you do have to be careful when you're using hypotonic solutions, when you're using hypertonic solutions that stay hypertonic. And we'll talk more about that later on. But when you're using those, you're got to be really careful with your monitoring because they cause really fast fluid shifts. So typically, when you have someone on IV fluids that's more stable, you'll probably see normal saline, lactated ringers. You'll probably see D5 half an S more. D5 half an S is hypertonic in the bag and slightly hypotonic in the blood, but the fluid shifts on that one isn't as fast as like a purely hypotonic solution. So you'll see some doctors give it for maintenance fluids. And I think a lot of things when it comes to like fluids, it gets a little complicated because there's different types of dehydration and whatnot. But just know that before I made like the Google Docs, I literally went looking up more info on how doctors prescribe IV fluids, and there was literally doctors, different professions, different specialties telling like the thread different things. Some people say normal saline for maintenance. Some people say D5 have an S. Some people say D5 have an S with some potassium in there. Some people say lactated ringer. Some people say no maintenance fluids. So it's very complicated. Even the doctors are struggling to find a consistent answer. So don't feel discouraged if it's kind of confusing um, in terms of that. Even the doctors don't know sometimes. But yeah, so you have your hypovolemic hypernatremia. We're going to treat that with some salt restriction, rehydrate the patient, have them take more water. We can also try hypotonic solutions because what's a hypotonic solution? It's more fluid than solute. So if someone has their cup of salt with a little bit of water in it, if you add more water with less salt, you can even that out without um, making it too salty or making it too hyponatremic. But you also got to really monitor your labs and patient presentation because it causes rapid shifts. So when things are hypotonic for too long, what happens to the cells, or how does the water flow? And of course, yes, as Jingle mentioned, yeah, the daily weights is always important when you're giving solutions. Fall risk is really important, all that good stuff. Yeah. So yeah, so Kayla, Alexis mentioned the cells are swelling up, they can burst. So you have that fluid moving or into the cells from the intravascular space. The way you can try to think about it is your water goes to a place of higher solute. So your water is always trying to even things out. So in the situation where you are getting a lot of hypotonic solutions, you're getting a lot of water, less salt. at some point, the salt or the solute in your cells ends up being higher than the concentration in your blood. So your water wants to make that more even. So it starts going into the cells. Okay. So when things are going into the cells, you can have things happen like what can think of some complications from hypotonic solutions or having rapid fluid shifts with hypotonic solutions. You have the cells bursting. What else? Fluid volume overload. You can get some of that. You can get edema in a very specific place that's really, really bad. Yeah, Kayla set the head. Yeah, you can get some edema in general, ascites, pulmonary edema, peripheral edema to some degree. A lot of that can be interstitial as well. But yeah, Kayla said head, so you can get cerebral edema. So you can get that buildup of fluid in your brain. You can have your brain cells burst, and that's why sometimes you have that altered level of consciousness with some of that. You can have that increased pressure in the brain. And that's really bad. And that's why hypotonic solutions require more monitoring. Okay. So we have hypervolemic. So you still have the same kind of signs and symptoms of hypernatremia here, but now you're gonna have that side effects from being hypervolemic. So what are some things we can talk about when it comes to hypervolemia in general? Get some bounding pulses, okay. High BP. Yep. Gonna have a little bit more high BP. You can have shortness of breath if it starts if that fluid ends up building up to the lungs and stuff. JBD. Yes, you'll have that JBD, that engorgement of that big vein near your neck. Increased respiratory, yeah. What about your heart rate? So we talked about the pulses. What about the heart rate? Increases, yeah. So compensatory as well. So when you have hypovolemia, your body has less fluid running through it, so your blood pressure is low. So your body's compensating by increasing the heart rate and respiratory rate. When you have too much fluids, so bigger is not always better. So your blood pressures increase. Having a higher blood pressure doesn't necessarily mean that you have better blood flow. It can get so high that it's causing issues. So your body is now struggling with that high blood pressure. It can be high systemically, so your body's struggling to get it pushed through where it needs to go. So your body starts compensating, have a higher heart rate, higher respiratory rate. Yeah, you can have some weight gain as well. So you can also include weight loss here as well. Because your fluid, how much does a liter of blood um weigh in liters? Did I say that right? Sorry. How much weight is a liter of fluid? So either gain or yeah, 2.2 pounds, aka 1 kilogram. Okay. So that's something to think about. So we'll write it over here. 1 liter of fluid, about 1 kilogram, which is equal to 2.2 pounds. Okay. Try to think more in kilograms than pounds because in the hospital we'll use kilograms. We use the metric system. Even in the hospitals, at least where I've been, the hospital beds are always in kilograms also. And that's in charting, it'll also be in kilograms.
No freedom units.
Yeah, no freedom units. This probably goes more right here. Okay, cool. Great. So what about the treatments for hypervolemic hypernatremia? So you have your cup is now really heavy in water and salt. So you have really salty water. Fluid restrictions can work, but your main thing is going to be your diuretics. Because what does diuretics work? How do diuretics work? Can anyone tell me how diuretics work? You pee more. Is that a layman's terms, or is this going to be maybe does anyone know the exact mechanism? Peeing more is kind of a layman. Anyone? Testosterone, decreased water retention. Okay. So it's not gonna block any of those systems you guys mentioned. It's not gonna stop RAS. It's not gonna do anything with aldosterone. It's actually gonna affect um, a lot of them are gonna just affect the kidneys and have them reabsorb less sodium. So the way diuretics work is um, they tells kidneys to release more sodium into the urine. So what happens when you release sodium anywhere? Your body, we want to think of if water follows sodium. So diuretics are directly getting your body to get rid of more sodium and potassium, and your body and your water just naturally goes towards it because your water always wants to go to the solutes. Water loves solutes, goes towards where the sodium and potassium are, aka P in this situation. So the layman, we say diuretics make you pee more. Reality is they make you excrete your electrolytes and then your water follows, which is why with diuretics, you're monitoring your sodium and potassium. Potassium more when so when it's Lasix. So for example, Lasix, you're gonna monitor your sodium, potassium more than anything, because that one can, as we mentioned, has a very small wiggle room. Your potassium, when it's abnormal, can lead to dysrhythmias, and some of them can be deadly, right? So that's why your diuretics are going to affect your electrolytes. Okay. And even with I'd probably even take the Lasix part out. There are potassium sparing diuretics, but even the potassium sparing diuretics, you want to monitor your potassium because maybe you have the opposite problem. Now you're building up too much potassium and now you have hyperkalemia. And we know that hyper and hypokalemia can both cause issues with your heart. So you're always looking at your diuretics. You're looking at with your diuretics, you're always looking at your electrolytes and your I's and O's. And obviously the patient presentation and stuff like that. So you're really going to be mainly treating this with diuretics. Um, yeah, any questions so far? Got a thumbs up. Cool. All right, so we're gonna move on here. So this is nice. So this is like a nice thing to review for you guys. Hyponatremia. We're gonna have hypovolemic hyponatremia, hypervolemic hyponatremia. So again, we're gonna include the same stuff here because it's gonna apply. This is all just from the hypovolemic part of it. What are some things you might see in hyponatremia specific to the lack of sodium? Yeah, pretty much a lot of the similar things. Altered level of consciousness, for sure. What about your muscles? How do they go? Yes, seizure is a big one when it comes to, yes, seizure risk, especially when you have your sodium under 25, 125. So your muscle's going to have those twitches, just crampings. Um, you're going to associate that more with your hyponatremia. Something you can see as well is some of that nausea, vomiting, diarrhea going on. It has that increased GI motility. Okay. Anything else you guys can think about? Deep tendon reflexes. Trying to think about that. Increase urine output. If we are hypovolemic, then probably yes. It kind of just has to go with the hypovolemic part. I think we're good on that. Yeah, you can have decreased urine output if you're hypovolemic. Your body's not making enough urine because you don't have enough fluid to make urine. So we'll just kind of go with that. And we'll include that as well in your hypovolemic, because this is just general hypovolemic stuff here. Okay. Pretty much about the same thing. GI motility, I think GI motility should probably be more for hyponatremia than hypernatremia, but you have a little bit of this going on, so I'll just get rid of that. Ooh, accidentally full screened. Okay. Ooh, okay. Yeah, I think the diarrhea, GI motility is more for hyponatremia than hypernatremia. Okay. But the main thing you really want to think about is probably your treatments more than anything. Just know the generalities. So we know sodium can have that effect on your muscles. It can have an effect on um, your level of consciousness. Think about how hypovolemia and hypervolemia affect your condition as well. When you have really low sodium, it starts to affect neurologically increased risk of seizures. So what are some treatments for when somebody has low salt and low fluids? Yeah, just give them some normal saline. Normal saline, you're quite literally, that is literally giving them both at once. So typically just their normal saline. This is a lot. Also your volume expander when you want to think about what are things that expand your blood or volume. That's going to be your isotonic solution. So your normal saline, your lactated ringers, and stuff like that. Is there anyone still having a hard time getting into the room? I think we might be okay on that. I think we're all here. That's a lot of people. We have 30 people in here. Jeez. It's hella people. Okay.
Oh, you said 30?
Yeah, we have 30 people
Jesus.
in here. That is a lot. Okay, cool. How much do you guys have in your cohort, by the way? Out of curiosity. Anyone know? Can I check that? Hold on. Be a chismoso here. I'm just curious. Is it this one? Yeah, N220. Oh, what does the chat say? Yeah, I'll send the PDF once we fill it out. 41. All right, let's see. You said 41. Let's see. Can you filter students? No. I'll trust you guys on 40. That's a good amount of people. Cool. Yeah, but yeah, you're gonna get normal saline because it's gonna give you both your salt and your water. Okay, so now hypervolemic. Again, we're gonna have some of these hypervolemic signs and symptoms, as well as some of your hyponatremia stuff, which is gonna genuinely be the same thing here. But the treatment's gonna be different. So what are we doing for someone that has um high amount of fluid and low salt? Or high fluid and low salt, rather. Says their blood pressure, heart rate, pulse, as well as listen to their heart sounds. That's all very good. Restrict the fluid. Yes, we're going to be doing some fluid restrictions. Anything else you can think of? And says K sparing diuretics. So with this one, we don't want to do that as much just because, yeah, pickles. I like that answer. I was looking for that answer actually. Yeah, you want to increase your salt intake. The reason again we're worried about doing things with your diuretics for this one is because even though you have a lot of fluid, remember that the main action of diuretics is to get rid of salt and potassium, and then the water follows. So if you have low salt, we're not going to want to decrease it more because then you can potentially have that issue where you have that seizure risk from having critically low sodium. Okay. So maybe I'll have a little section where we just talk about diuretics right here. So let's go over your loop diuretics as well as your potassium sparing diuretics. So what are some examples of loop diuretics? Furosemide, yep. Furosemide, Lasix, same thing. That's the brand name. And there's another class of diuretics. Yeah, they're thiazides. Yep, they're also going to be potassium wasting. Technically, thiazides are not called loop diuretics because they affect a different part of the renal tubules. I think that they affect the renal tubules instead of the loop of Henle, but it doesn't matter. We're just calling these potassium wasting. Call it a day. Yeah, for these again, you are monitor NA and K, especially K for especially hypokalemia. I'll just write that hypokalemia. Okay, and your potassium sparing diuretics, the ones that the one that we actually know, there's like one. I think there's more than one, but I don't know the name of it. Spironolactone, and what is the brand name for this?
Aldactone.
Aldactone. Cool. Yeah, so this one's the potassium sparing, and you still, even though it's potassium sparing, you want to assess the K, especially hyperkalemia, because then if you're keeping it a lot, it might cause you to then build up too much. So that's just a quick review on diuretics. Does anyone have any questions at all on anything we talked about yet? So far, rather. We talked about this rule here, 1 liter of fluid equals 1 kilogram. We talked about the different diuretics, the electrolytes. And really for this, just kind of try to find a way to have general ideas of the signs and symptoms. It's very rarely going to be like you're going to be getting some sort of question where it's like I know we had some Kaplan questions that were really confusing when it came to the F&E chapter that were like, oh, this sounds exactly like this other one, but it's not. It's this other electrolyte imbalance they're just really similar. The focus is just trying to getting understanding the treatments as well as general like idea of how they affect their body. Okay. So kind of just always think about stuff like muscle twitching, altered level of consciousness, nausea, vomiting. If you have hyponatremia, start thinking about seizure risk. Starts thinking about your nausea, vomiting, and maybe some diarrhea involved into it. Okay. All right. So now we're going to talk about potassium. Okay. Does anyone know why there's a hypo and hypervolemic versions of your sodium imbalances, but there's not one for your potassium? Yeah, the majority of your potassium is inside the cells, and the change to your intravascular doesn't affect the potassium as much. So generally, your hyper and hypokalemia are treated the same way, regardless of if it's related to maybe some influence by your intravascular fluid. Okay. So what are some signs and symptoms of hyperkalemia that we can all think about? Potassium doesn't follow water as well. Zach, it's the other way around. Water would follow the potassium. So water follows the electrolytes. Osmosis is all about water movement. Peak T waves. All right, girl. Your arrhythmias, yeah. Try to keep it basic. I said keep it basic. But yeah, it can cause peak T waves, but we don't need to know that. Keep it basic. That's 240.
Bruh.
Even not even 240. We didn't really go too deep into that. We know it's a thing, but it's not like, oh yeah, we gotta know it. Yeah, muscle weakness as well. That's a big one. So we start thinking about muscle weakness, muscle paralysis when it comes to your hyperkalemia, tachycardia. Mm, I feel like if you have a change in heart rhythm with your high potassium, it'd probably be the opposite. I'll double check up on that because typically your potassium is um your resting electrolyte. So in terms of like muscle movement, your sodium and your calcium cause contractions, and then your potassium causes relaxation. Does this one cause constipation or it's caused by it? So let's think about that. If you have high, I think it's more like caused by it. Um, so okay, so let's talk about Fidel says low heart rate, low blood pressure. Um, Potentially, but that's not kind of like the main thing you want to think about. You want to think about your arrhythmias, muscle weakness, paralysis, and there's another thing. So it kind of goes along with that muscle weakness. What's a muscle? Think about your ABCs. What's a muscle that you think would be heavily impacted by muscle weakness that could be really bad on your ABCs? Yes, so you're going to have respiratory issues related to muscle weakness, aka your diaphragm. Okay. It's actually going to be a little bit of both. It's going to both hypo and hyper can have that muscle weakness. So both hypo and hyper are going to have muscle weakness, paralysis as things that can happen. Um, and both of them can affect your diaphragm. Just in general, when you think about systemic muscle weakness, when you think about body-wide muscle weakness, think about how it can affect your diaphragm because you have a muscle that's dedicated to breathing, and so that's going to affect your breathing, basically. And Kellett says increase your eye motility. That is true. So we can have diarrhea. Why do you think that is? Increased peristalsis. Trying to get rid of potassium. Yeah, pretty much both of those answers cover it. So your body, how does your body get rid of potassium? It gets rid of it through the urine, and it gets rid of it as well through your poop. So through your GI as well. So naturally your body is like, oh, I got too much potassium. Let me just get rid of it real quick with some poop. That's why, yeah. So that's why your one of your treatments for is going to be a laxative. We'll talk more about that in a little bit. Okie dokie. I think in general, hyperkalemia is considered more dangerous than hypokalemia, but they're both can cause dangerous things. Um, so just think about that. Let's see what else. What else? What else? Yeah, so I think Fidel previously mentioned decreased blood pressure, slow heart rate. That is a thing that can happen. I'll write it down. I think your main focus is probably on probably the first three mentioned, but I can include that. Sorry, yes, but I think my brain just not working today. Okay, I think it's lower BP, slower heart rate. Okay, what else did we mention? Let's see. Uh, uh, uh. Just double check on, see if I missed anything that I wanted to go over it. Um, blah, blah. Sorry, I'm just making sure I don't miss anything for this. Abdominal cramping, blood pressure decrease. Yep. So yeah, so I think someone mentioned Kayla. I think you mentioned. You attributed the respiratory or general like paralysis less so in you attributed more with hypokalemia. I think. I think it's maybe less pronounced in hyper than it is in hypo, but that is a thing to keep in mind. Okay, so let's talk about. I think someone said DTRs. I don't know. I think I saw it, then it stopped being there. Maybe I scrolled down too far. I believe your deep tendon reflexes. I think also, yeah, I don't know if it's increased. I think it might be decreased. I think it's a decreased deep tendon reflexes. Someone correct me, or by someone I mean Kaylin. Correct me if I'm wrong. I'll go check up on
I'm
that
gonna have
though.
to check that.
Yeah. Again, it's not one of your like super huge things to think about. Your main thing you really want to think about is your pulses and your EKG changes, or well, EKG as in your heart rhythm. It affects your heart, affects your respiration, all of that stuff. Yeah, I think it's absent or depressed DTR, deep tendon reflexes. That's what I figured. Yeah, and I think it's also the same for hypo. I think hypo also causes that. So I'll put it over here. Decreased or absent deep tendon reflexes, but it's not your priority side effect. So what about treatments? When you have really high potassium, how are some of you have okay, insulin. It's a good one. You have a mnemonic, so it's like C big kid, or is it C big KD? Yeah, C big kid. So talked about insulin, but are you going to give insulin just by itself? No. So part of this part right here, the I and the G stand for insulin plus glucose. So the basic idea is insulin pushes, probably write it like this. Insulin pushes potassium and sugar into the cells to be used. Kind of think of insulin like the key, and it utilizes some potassium to open that door so sugar can get into the cells to be used for energy. So for that reason, having insulin is giving someone insulin is going to help push potassium in, and then we're also going to give them glucose so that they don't become hypoglycemic. Okay, so that's your I and G. Anyone else mention anything else? Mary mentioned calcium gluconate. There's also calcium. I think they use it's gluconate and I think carbonate maybe that they can use. Basically, just calcium. You can get calcium. The calcium can be used. Yeah, it's calcium chloride or gluconate. Okay, or calcium chloride. It's going to be a temporary shift of potassium into cells. Let's see, calcium, laxative, diuretics, dialysis, bicarbonate. So the K is for, yeah, bicarbonate. B is for bicarbonate. So this is a base. So when you have high potassium, you also have acidosis. So that's kind of common. So it's a base used to neutralize acidosis, and it's also going to be good for that potassium. You have K for kaaxylate. So this is, I thought it was a laxative, but I guess it's more of a potassium binder, and it uses it's a slow working potassium binder that helps to remove potassium through feces. And then D is for diuretics or dialysis. Probably dialysis more than that. I've never seen diuretics for someone trying to do this, I guess. I think this is usually like last resort. We need to get rid of it. Kind of like your last resort. Get rid of potassium. Yeah, I've seen more dialysis than diuretics. So I'll do it like this. So diuretics. So someone that has really high potassium might get dialysis and you need it now. You have all that you're symptomatic and you need to get rid of that potassium now because that's an extreme thing. If someone's having potassium shift and they're not they don't have like kidney disease, it's just like an acute case, then it's not really common, it's not really normal for them to get dialysis. Um, but they're getting it because that's how bad their condition is. So it's when someone is really bad. And I believe Miss Gonzalez, I believe she still teaches this lecture or taught this lecture in 212. She also mentions that the order of CBIC kit is also kind of in the order that it gets done sometimes. So you'll have this temporary one, maybe while the caxylate is waiting to work, or you'll do the bicarbonate, the insulin plus glucose to push it back in, and then diuretics is your last resort. Okay. Any questions so far? You all good? All Gucci? Okay. What are some things that can cause potassium or potassium overload, hyperkalemia that you guys can think about? Your DKA, yeah, that can cause that. And you'll notice that your DKA kind of goes along with what we talked about, how insulin is one of the potential treatments. When your body is not able to respond to that insulin, then your body's also not able to put some of that potassium in the cells. So you can imagine then if you don't have successful management of your insulin, then you're also not going to have good management of your potassium into the cells. So that kind of can help twist, or not twist, it can help you align both of them with each other. Maybe helps you remember it better. And mention medications. So what are some medications you guys can think of? Kayla already mentioned one. She mentioned potassium sparing diuretics. So spironolactone. What else have we got? IKEA said ACE inhibitors. So yes, ACEs and ARBs. Both of those can increase your potassium because they block the aldosterone. And something that I was remember telling you guys is your aldosterone is going to cause a release of, sorry, it's going to cause a retain sodium and water, or rather, it's going to retain sodium, which causes a retention of water. And it's also going to release potassium. So when you're inhibiting this, you're doing the opposite. So if you're inhibiting your aldosterone with your ACE inhibitors, you're now releasing sodium and water and you're um, keeping potassium. You guys see that? In soft altitudes, yes. So you guys see why your ACE inhibitors are going to be doing that to your potassium? Okay. So what else did you guys say? You guys said NSAIDs. Yes, so your NSAIDs are related to your kidney stuff. So NSAIDs, why? Because they're nephrotoxic. I'll just write nephrotoxic medication. And we said salt substitutes. Yeah, so that's something to keep in mind. You might get some questions where it's like, oh, I've been recently diagnosed with kidney disease and I was told to watch my, uh, actually, I guess it'd be more like, someone with kidney disease been told that, oh, I need to watch my salt. I've been taking salt substitutes. It's like, actually, no, you can't have that either because you're potassium. And yeah, in general, substances. Yeah, so another reason we said nephrotoxic, so kidney failure, kidney disease is common. Anyone had a kidney patient in clinical? Yeah, how did that go? Did they have an AV fistula? Oh yeah, he had ESRD. He got dialysis. Cool. Was he able to make urine, or was he full no urine? Nope. Yeah. So that's the thing you'll see is a lot of ESRD people will not make any more urine. They'll need dialysis to get rid of all that waste. And one of your things that your kidneys are responsible for getting rid of is your potassium. So if your kidneys are not working, your potassium release is also not working very hot. So you will have those instances of your hyperkalemia as well as other electrolyte imbalances that you will learn more about next semester. But for now, here we are. Awesome. Any questions on hyperkalemia? I think we did a lot so far. Making sure that we're good on time. Ooh, okay. Maybe we go a little bit faster. Okay, so what are some potential causes of hypokalemia? Yeah, malnutrition can be one. Not being able to eat, nutrition output, NPO as well. Your loop diuretics, yep. NG suctioning, great. That's great. Nausea, vomiting, perfect, perfect. And diarrhea as well. Wound drains, yes. Wound drains, fistulas, I can see that. Bleeding in general, bleeding, fistulas, perfect. So, what about, yes, I was looking for that. Thank you so much. So, too much insulin. Likewise, here, if you have causes DKA slash poor insulin, poor diabetes management, hyperkalemia. So likewise, too much insulin, hypokalemia. Perfect. Perfect. So what about some signs and symptoms? Just kind of get all the basics down. Try not to look too deep into things. It's all about getting the big picture here. For sure. Got that EKG changes, your arrhythmias, arrhythmias, shallow respirations, yeah. So very similar to the other one where you will have muscle weakness, paralysis, respiratory issues related to diaphragm weakness, diaphragm, diaphragm. Okay. What else was I saying? Respiratory changes, muscle weakness, orthostatic hypotension. Yeah, orthostatic hypotension. You have your, I think, oliguria with this one. So less urine output, maybe like a thready pulse. So this one's not oliguria. This one's polyuria. Sorry. Constipation. Belief. Yeah. Constipation because your GI motility decrease. Cool. Paresthesia, yeah, kind of goes along with that. I think you also have decreased deep tendon reflexes as well on this one. But your main thing you really want to focus on is your arrhythmias, your muscle weakness and paralysis, and your respiratory, and maybe also your hypotension. Those are probably the number four, the top ones that you want to think about. Cool. So let's talk about some interventions. How do you think we fix low potassium? Yeah, by giving potassium. How do we go about giving potassium, Anne?
It's 10 MEQ an hour.
Yep. 10, you might see 20 depending on the how critical it is. I've seen 20 a lot. Um, so which one do you think is more effective for a patient with poor, like really bad potassium? Your IV piggyback or your PO? Because you can have PO, you can have your snacks, you can have your
PO.
PO.
Mm-hmm.
It's gonna be your IV for more effective.
I thought you know what? Because my patient, they gave him a PO and he was like 2 point something, and they gave him a PO.
You're right, Rosemary.
Oh wow, I did not know that. I was gonna say
Yeah,
IV.
it's quite ironic if you come to think about it, because for the most part, we look at IV piggyback and it's going intravenously, so we think, oh, okay, like it's gonna be like the most effective. I don't know why this is. I just know that it is, that the absorption of potassium is significantly better PO for someone with really low potassium than IV piggyback. I think it has something to do with, the fact that we can only do a very, very slow amount.
Hmm,
Um,
that makes
but
sense.
typically PO is better in terms of absorption.
All right, I did not know that. That's good to learn. Thank you so much for sharing. Cool.
It was show and tell time.
Yeah. So PO, there's IB piggyback. PO is um better for, how would you word this? Better for improvement? Is that the word?
Better in terms of absorption.
Probably, huh? Better for absorption. And then IB piggyback. Try to not do, we never IB push. So no more than 10. I think they teach you specifically 10, but I've seen 20 a lot in like other places. But for now, I think they just teach you no more than 20. Then sorry, no more than 10. Or have they ever told you guys more than 10 before? Because I've definitely seen 20 often. Okay, cool. Yeah, I've seen 20. Yeah, so no more than 10 to 20 MEQ per hour. Perfect. IB piggyback.
It depends where you're at,
It
depends on
does.
what's going on with the patient too. Like the typical rate you see is 10, but if the patient's like real down bad, you can very technically go up to 20. Like ICU, you might see 20. That's something that we
Hmm.
learned recently,
Yeah.
did you go? But yeah, it definitely not over 20 though.
But yeah, so naturally you're also looking to see that you don't put them into hyperkalemic, you don't put them into a state where they're gonna then have some arrhythmias. You're not gonna fix you're not gonna overcorrect the mistake. Same with your fluid when you're replacing your fluids and stuff like that. Okay. So I think that's about it. Someone said O2 therapy. If you have those respiratory issues, then sure, we can definitely do that. But that's kind of just your main idea with your hypokalemia. Okay. And for here, I think we'll just talk through this one real quick. Just, does anyone know their normal chlorine value? I think again, the focus is sodium potassium, but just make sure you got it decently down. Yeah, yeah. We got a lot of different values just because a lot of different hospitals have it on different values. I think I remember from our PowerPoints, it was like 98 to 10 something. I think 108, 98 to 108 or 98 to 106,
Something like that. As
something
long
like
as you're
that.
in the range.
Yeah,
It's gonna be different per hospital,
it's gonna be
so as
different
long
per
as you're in the
hospital.
range.
So maybe I'll cut this part out because you're not really gonna be tested on these
As of right now.
as
If
of
you
right now.
know it for clinical though.
Oh, for
But
clinical,
but right
but
now they finna get ready for the test, so
yeah.
it's
So
not much after
yeah,
that.
I'll just throw in the line here if you want to use it for reference. This is acid. This is for the chlorine is useful for acid base balance. Magnesium and potassium can be used acid base balance. Um, when abnormal, it can cause dysrhythmias. Calcium can obviously cause bone fragility. Maybe some nerve issues. You have the Bostic sign or whatever, muscle weakness as well. Um, but a lot of the time it can be asymptomatic, but we won't focus on that just because again, we have like 1 more hour and I want to make sure that we get through everything. And this is just like me being extra for no reason, as usual, as per usual. So we'll move on to just your fluid spaces. So just like a quick thing here, intravascular, can someone explain intravascular versus intracellular, interstitial? Just like the quickies.
Can try.
Yeah, go for it.
So the extracellular is basically divided into the intravascular and the interstitial. Basically, any fluid that's outside the cell, so that includes within the blood vessels and the spaces between the cells. And the other type is intracellular, so basically all the fluid within the cells.
Yeah, so this is fluid in the cells. So this is kind of what your blood pressure measures is your blood pressure essentially. Fluid in the cells, intracellular is obviously fluid in this. Did I put? Sorry, I brain. Fluid in the fluid in the vessels, not the cell. Fluid in your bloodstream. That's probably better. Sorry, my brain is fried.
Oh, I felt that one on a It's
Yeah,
been a week. It's been a week, guys.
this is just fluid in third spaces. So in between the cells, in between the in between the cells and the intravascular. So this is where you'll get your third spacing is when you have fluid in your abdomen, ascites, peripheral edema, pulmonary edema, cerebral edema, all those edemas, all the edemas and the ascites.
Wow.
Okay, just kind of a general idea. Just know what third spacing is. I'm sure you guys had a question on your 212 exam that's like, what's third spacing? And you're just like, yep, it's it's this, or whatever.
I remember that. Good times.
So now we're going to talk about isotonic solutions. Some examples. What are we thinking? Yeah, normal saline. You got your lactated ringers. You got your D5W. Yeah, perfect. And we'll just go through the examples first. What are some examples of some? Is D5 1/4 enough? Isotonic.
Uh,
I'm not sure if 1/4 NS. I don't think I've ever seen that one. Oh, was it? Okay. This. Hold on, let me just make sure I'm not trolling you guys.
in terms of what?
D5W is isotonic, right? Or no? Is it hypotonic?
Oh, geez, I believe it's ISO and
I
then
believe
goes
it's ISO. Yeah.
hypo. I'll double check while you do the rest.
Yeah, okay. Give me some. Yeah. I was just wondering, like, in the bag versus in the blood.
In the
So
blue.
hypertonics, Jingle, hit me up with the 3% NS, perfect. This is where you got your D5 NS, D5 LR, D5 half NS, D10W, yeah.
Like,
And then your hypotonic, I'll just do this one real quick. Half NS, 1/3 NS are the main ones that they really go over. I'm sure 1/4 NS exists, but I've never seen it, but I'm sure it exists.
bro, I ain't seen nothing other than normal saline, lactated ringers, and D5 half. That's all I've ever seen in my
That's
lifetime.
that's true. I've never seen anything else either. That is very true. And like I said, doctors will be like, use this for maintenance, use this for maintenance, actually use this for maintenance. And someone's like, don't use maintenance fluids. Just don't use maintenance fluids ever. Or, stuff like, it gets really complicated, your fluids. Okay, so let's just talk about isotonic. It says, in terms of this is a question, would ISO be a maintenance fluid? I don't think that would be a question like that. I think at most the main thing you want to think about is the role of isotonic, which is, I think I think you guys have Hyfley for this, so I'm sure she's set this. What is the role of isotonic? Starts with a V, and then the second word is an E.
Oh, I was like, what? Okay, I got you. I got
Yeah,
you.
you
I
get what I'm
catch your
saying?
drift.
What's your bar? Ooh, it's one of these. Yeah, that one. The volume expander. So when someone's crashing with their blood pressure, your isotonic solutions are the ones you're gonna bolus them with to increase that volume. So it quite literally does what it says it does.
I would hope so.
Yeah, I would hope so.
It does what it says it does. Really? Don't
Yeah.
say. I'm just gonna
Yeah,
get you.
so that's our role for this. So how are we using it? So we kind of talked about it's going to expand the volume, but what is like the big draw of the isotonics?
It's no shift.
Yeah. So basically little to no shift in fluid. So it's just going to be intravascular. It's going to stay in the intravascular for the most part. There's different types of dehydration. You don't need to know them, but some people can have dehydrations of different kinds, and that might cause some fluid shifts just because someone can be cellularly dehydrated only or is intravascular dehydrated only. But again, extra stuff you don't need. Just kind of
Oh,
think of your isotonic as your volume expanders, and it's good because they don't cause as much shift in fluids. Okay, and we talked about your NS can be a good way to get sodium on someone that might be low on their sodium, but not too low. Because if they get too low, that's when we'll get the higher percent normal saline. Okay. What about hypertonic solutions? What is like a theoretical usage of hypertonic solutions? You guys went over this in one of your homework assignments. I'm sure you guys still had to do that one homework assignment where it's like you guys have like a chart and you're like, okay, what are we using this for?
I barely remembered that.
Answer cerebral edema. Yeah, that's true.
Yes.
So hypertonic or hypertonic. Severe hyponatremia for a 3% NS, definitely could be used for that. For heart failure, I would definitely not want to give someone with heart failure hypertonic solution because if you're giving them, remember hypertonic is lots and lots of solutes.
And where's all the fluid gonna go?
Yeah, all the fluid's gonna go into your intravascular, and someone that's already having issues pumping is not gonna want that um, extra stuff. So let's see, let's say for 3% NS, it's gonna be good for resuscitation of NS or good for rebuilding. What's a good way to phrase this? Good for severe hyponatremia. Let's just do that.
Or just sodium less than 135 or 125,
125.
however
Yeah,
much it was.
yeah,
You know what I mean.
yeah. So what else do we got?
Oh.
So talked about cerebral edema, and that's correct, but I want like the generalized. So it's good for cerebral edema. Why? What's it doing that makes the cerebral edema good? Or that makes the cerebral edema less bad? Pulls the fluid out of the cells, exactly. So the idea is that hypertonic solutions
Shrank it.
can shift fluids from cells to intravascular.
Shrank it.
And this can be used to treat edema. Why? Because edema alongside diuretics. Why? Because the idea is your hypertonic solutions pull water out of your interstitial spaces or your brain, your cerebral cells, into the blood so that then your diuretics can cause you to eventually get rid of that fluid from the intravascular. Does that make sense? Does everyone understand the idea behind that? Hypertonic, push everything into the blood so that you can get rid of it. Okay, so that's like a theoretical thing you can use with hypertonic solutions. What about for the D5 and for ascites and third spacing? Yes. So again, anything that's edema, anything that's third spacing, anything that's ascites, your hypertonics can, in theory, bring those fluids back into the intravascular, into your bloodstream, so that then you can use diuretics to get rid of it. Okay. What about the D5s? I don't think you guys go over too hot on the dextrose containing solutions. I think I talked with some of you guys in the skills lab about it, but I don't know if any of the people I talked to there are here. But I kind of just briefly mentioned what the dextrose 5% is good for in theory. Diabetes, someone that is maybe it's not going to be as good for hypoglycemia. Hypoglycemia, remember we do D50, 50%. But yeah, I don't think you guys went over this, and this is again being extra. But so in theory, eating after surgery. It's good for those that so in theory, the dextrose, like a full bag of like 1 liter of D5 half an S, for example, can give someone enough calories in theory to not muscle waste your body. It gives you enough calories so that your body's not breaking down muscle. So it prevents muscle wasting due to calories, essentially.
Well, that would be super short term, no?
It would be like
Okay.
it's just the concept would be I don't want this guy to muscle waste, so just give him some D5 half an S.
Okay.
And in general, I guess from here we'll talk about probably should have had this here. In fact, this probably makes more sense here. So remember that the ones that are D5, you guys mentioned this already, but the body metabolizes the D5, and you're left with whatever is left. You're left with and then you just have the rest, essentially, in theory. while that fluid is infusing, your body is constantly breaking down the sugars and then being left over with the half an S, for example. So if you take the D5 half an S, your body is metabolizing that sugar and then being left over with half an S. But because it's continuously being given, it's consistent. It's like consistently metabolizing that sugar. So it's not going to have the full hypotonic effect that you would expect from half an S, which would have a really big shift of fluids, but it's still going to be overall hypotonic in the blood. Um, the solution. I don't know if this makes sense. Like if you were to read this without the context, does this make sense? If you were to just read this, like if you were studying 2 weeks from now, so D5 half an S becomes half an S. Cool. But just keep in mind that it's not going to be as strong of an effect because you still have some of that sugar there that is still being actively metabolized at the same time. Anne says I wouldn't understand it. Okay, bet. Let's see. What if with this example, does that help? Anne? Oh, bet. Okay.
Yes, it does. Thank you.
But yeah, that fluid shift from the D5 half an S, like D5 half an S versus half an S is going to have a much higher effect on the fluid shifts than D5 half an S, just because your body is, even though your body does metabolize that sugar, it still has to metabolize the sugar. Metabolizing the sugar is going to make a little bit more water because your Krebs cycle ends with water formation, and you still have that D5 in there being metabolized at the same time, so your fluid shifts aren't as big, which is why some doctors might give D5 half an S for maintenance fluids because it's not the same as half an S entirely. Does that make sense? Am I confusing people? Am I saying too much? Hello? Hello? Okay.
People are saying yeah.
Okay, cool.
Pay attention to the chat, Diego.
I'm looking at the chat. I think it's just some people have it on PMTU only or something. All right, cool. Just making sure. So if you've ever been like, oh, I read half an S, it has those huge fluid shifts and it can cause this, but the doctor just put someone on D5 half an S and they're okay. It's probably because a lower dosage of the D5 half an S is not going to have the same amount of fluid shifts. Maybe that makes it better. Okay. So usage. I mean, just kind of shift fluids into intravascular. We good? We good on this? Any confusion on the hypertonics? Cool. And again, even though this is even though this is shifting things into intravascular, if someone has low blood pressure, you guys went over shock last week. So if someone's in shock, we're not bolusing them with hypertonic. We're giving them isotonic because it's a volume expander. It's not going to cause massive shifts. Even though this is shifting fluids into the intravascular, we don't necessarily want that because then if you're shifting too much, your cells then become dehydrated and you can have the cells shrink and they won't burst, but they'll shrivel and die. So just remember that. We always use isotonics for like low blood pressure, bolus, and shock or anaphylactic shock or all that stuff. Okay, this is your go-to pretty much. I'll just put go-to for low blood pressure, stuff like that. Is that too generalized, Kaylin, do you think? Or this is okay?
Huh?
You think this calling it the go-to for low BP too generalized, or do you think it's okay?
I think it's fine.
Okay, cool.
I mean, it goes in line with volume expander. It should be fine.
Yeah, cool. So just remember that. Okay. So if you see a question on your exams that's like, oh, dude, it's bleeding out, he's got a shock. Are we giving him the solution, are we giving them isotonic or are we giving them hypertonic? You think, oh, hypertonic moves things to the bloodstream where we want it, but just remember the fluid shifts cause not just obviously the fluids to move around, but it also causes changes in your electrolyte concentration, and your electrolyte concentration can have a lot of problems as we mentioned here, right? So if you have massive fluid shifts, it can affect with their cause shifts in their hyponatremia, cause hyponatremia, or whatever. Even though the hypokalemia aren't as affected by the fluid shifts, it can still have some effect. So we don't really want to cause that. So just remember that. Okay. So what about hypotonic solutions? What are some of the roles that we use them for? Okay, yeah, it's cellular rehydration. Perfect. Which is good for prolonged dehydration, but just keep in mind dehydration. Yeah. Just keep in mind that this is context-based, meaning that very likely to also seen for severe hyponatremia. Yeah. So again, context-based. Don't just be like, don't just be like, oh, we need to rehydrate their cells, so we just slam it. Just think about how these requires more monitoring requires more monitoring. So, for example, likely for someone with prolonged severe dehydration to have what? Yes, Caleb, that's right. We're gonna volume expand, and then when they're a little bit more stable, then we're gonna go for hypotonic. Because again, we don't want to have those massive fluid shifts on someone that is potentially fluid starved. Because again, that can cause really bad electrolyte and maybe some acid-base imbalances going on from all that fluid shift. Even someone that is getting dialysis, there's like a dialysis disequilibrium syndrome, which is like the massive shifts in the fluid and the electrolytes causes them to have really bad side effects. So someone getting dialysis can have things happen because their dialysis went too fast, for example. So kind of think about it. To get minus first, then have hypotonics. Okay. Let's see. And this is going to be shifts fluids into cells. Yeah, and then hypotonic. Yeah, we would start iso and then go hypotonic. Because at the end of the day, if someone is severely dehydrated, we need volume expander. So again, go for low BP dehydration. I'll put that here. If they're severely dehydrated, they will likely have low blood pressure and stuff. So we need to expand the volume first, and then we can start playing around with the fluid shifts. Okay, so think of it like this: you use your hypertonic and your hypotonic when you want to shift fluids around, but somebody with severe dehydration or low blood pressure or in shock doesn't have that much doesn't have that much volume to play around with. So you want to play around with more volume, so we expand it first. Does that make sense?
Yeah.
Cool. Okay. So let's fill this one out first. So fluid electrolytes is heavily tied to a concept. So I'm looking for a concept. Concept here. Insert concept here. And what concept do you think is involved with your heart and your kidneys? I'm sure you guys have done care plans where these two are super close to each other. Any heart failure people probably had to do care plans on perfusion and fluid electrolytes or oxygenation or all three. It's very
Wonderful.
tied heavily to perfusion. When you have poor perfusion, yeah, concept is perfusion, exactly. So yeah, when you have the fluid electrolytes, we know potassium can affect the heart. We know when your perfusion's off, it can affect the heart, but also keep in mind that perfusion issues are affecting the kidneys. Your kidney is like a needy boyfriend or girlfriend. It needs that blood. It needs that sugar. Well, not literally sugar, but
Oh.
metaphorically.
Oh my God.
It metaphorically needs it. So when your kidneys aren't getting it, so remember your shock. One of Into stage 2, your kidneys are already starting to suffer, even though your body is shunting your blood to your vital organs and your kidneys and your liver. Your kidneys are already starting to suffer just because they're not getting as much as they need, and they need a good amount of blood. So your kidneys immediately start crying out. That's your body starts shunting, your body starts bearing down, clamping down rather. Yeah, so your kidneys can get affected, and if your kidneys are getting affected, what are some things we can think about that you might see when your kidneys are shot? Your FBO, exactly, low urine output. SG, SG, no.
Specific gravity.
Oh, I was like,
Wow.
true. So, but you have a high or a low specific gravity if you're not peeing? You would have a high specific gravity, exactly. So you would have very little urine, but when you do get that urine, you get concentrated urine, which makes sense. When you're really dehydrated, like maybe go a few hours without drinking, your water gets more yellow, or maybe it gets even orange if you're that dehydrated. So that means it's really concentrated. But if you drink a lot of water, your pee starts looking like water, starts getting clear. Hmm. So yeah, we know that, hyper and hypokalemia can cause issues with this. Your sodium can affect blood pressure, which is why people with heart failure tell them back off on some of the salt, because that can increase your blood pressure. Because again, water follows salt. Water follows electrolytes. Yep. So some labs here we can include your H and H. So when you're dehydrated and when you're FBO. So how's your H and H when you're dehydrated? It's going to be increased. And when you're FBO, it's going to be decreased. So your H and H, think of it kind of it's your concentration of red blood cells compared to your blood. So when you're dehydrated, you have less. Imagine like a cup of blood. You have less fluid and more of the actual cells, so you're increased. When you have too much volume, uh, because your red blood cells stay the same. Your hemoglobin's typically going to stay more stable, unless you have other things going on. Um, and it's your fluid that you're playing around with. So if you have your red blood cells stuck at like a value of 1, and then you're dehydrated, you have less than 1. So let's say normally, I think I'm explaining this poorly, but let's say if it's like a ratio of red blood cells to fluid, if your red blood cells are stuck at 1, but you're dehydrated, and let's say it's normally 1 to 1, but now your fluid is half, right? You can plug this into a calculator and you get 2, right? So think of it like that. So when you're dehydrated, you have less fluid, so you're dividing by less than 1, so you get a bigger number. So that's why your H and H is increased. Am I making it confusing? Is that confusing? No? Well, I hope not. So so dehydration and increased H and H. But if your normal is 1 to 1, and now you have twice as much fluid, you have 1/2. So that's your H and H. But that's why you see your H and H is now decreased. Okay. So think of it like that. Think of your RBC as a stable thing unless you have something else going on. And then if you're just talking about your fluid shifts, you're thinking of that number 1 being divided by either a lower number because you're dehydrated, which makes sense. You have less fluid, so you're dividing by a lower number, and then your H and H ends up being higher. So that's why it's like that. And then you have the opposite. If you have your RBC stuck at 1 and you have twice as much fluid going on, you see 1 divided by 2 is half. So that's why your H and H trends that way. Okay. Cool, cool, cool. What are some other labs? So I guess we talked about it here. So I'll just kind of increase this. So urine output are things to look at. specific gravity are things to look at. See fluid status. Labs are inconclusive in dehydration. That's true. Let's just go with eyes and nose. I'm just kind of giving an example. You may or may not, maybe. I feel like this is something you might have like a SATA on where they're like, labs that are good for fluid status. I don't know. I feel like it could be something that could, your osmolarity. So this is urine specific gravity. I think that could be a one. So let's just do osmolarity, like blood osmolarity, like serum osmolarity. Anything else? Yes, your BUN, exactly. So, kind of like when, like I popped in, to Kaylin's questions, when you have your, when you're really dehydrated, your body's not making as much urine, and your BUN is basically one of your waste products that your body gets rid of through urine. So you can have your BUN increased when you're dehydrated, because you're not peeing, so you're not getting rid of that waste product. Okay. Typically it kind of goes like that. I think when you're FBO, the FBO part doesn't directly correlate with that, with your dehydration, because if you're FBO, you could be FBO because your kidneys are shot, in which case your BUN would still be high because you're FBO but not making urine. But a lot of the time, your BUN is going to be less kidney specific and more hydration focused. So your creatinine and your GFR are going to be more of the kidney function ones, but your BUN can be used to determine hydration status. So I'm sure you guys have seen patients that have increased, that have your BUN that's increased, but their creatinine's fine, their kidneys function's fine. It's increased the BUN because of their dehydration. Okay. Anything else you might think about? What about some physical assessment things you could see? Yeah, your blood pressure, pulse rate, perfect. Pulse rate and pulse quality is good. Yes, so body temp, as in, I guess skin temp is more accurate. Skin temp and color. Skin turgor as well can be one. Well,
Is it turgor or turgor?
are you saying how it's pronounced?
I have no idea how it's pronounced. That's what I'm
Skin
asking.
turgor. Skin
Turgor.
turgor? I think it's turgor.
I have no idea.
I don't know.
I don't know.
I know I've never seen anyone actually do one, but
That's a lie. Everyone did one in 210, 212.
that's true. I meant in real life. Yeah. GIF or GIF? I say GIF. I don't know what the common consensus is.
I say GIF.
All right, cool. Wait, bro.
I love that for you. 10 out of 10. Bro, I laughed so hard right now, my back cracked.
Bro.
Ow.
Anything else you guys can think of? We got everything, you think?
I'm missing my sanity.
We got a lot of stuff here, so maybe neurological changes, that could be one. It's not really a lab status, but I guess some of these aren't lab status, so I'll just go indicators, put labs and assessment, I guess. But yeah, that's a good one. We'll just do that. Level of consciousness.
Ouch.
What about, will we go over devices? Devices?
Turgor.
IV.
I mean, like,
Hmm,
central line and peripheral lines. Do we have to know that? It was
Okay.
Not
hard.
particularly. Maybe the complications, but not like,
Okay.
yeah. You will review PIC line and all that central lines in next semester.
Okay, good to know. Thanks.
Yep. So complications. Right now for fluid status, unless you're asking about if we will go over complications, yes, we will. It's gonna be a little bit towards the bottom. What else? There was something I was gonna say. Oh yeah. So we can talk about our daily weights. Remember that. We talk about isonos, but also your daily weights are important. It's actually considered one of the best ways of telling someone's fluid status, or rather their change in fluid shifts, is actually your daily weights, or at least that's what we're told. And I believe her though.
I don't
Uh,
know. I change like 3 pounds a day, so I'm concerned I got like heart failure now.
Yeah, you can also assess the lung sounds and stuff.
Please assess
Crackles,
your lung sounds for crackles.
crackles. Maybe you have JVD, or oh yeah,
Crunchy.
your cap refill. True. So true.
Blue.
Yeah, that's a good perfusion one, as general. JVD, maybe flattened hand veins.
Oh,
Yeah, there's a lot of stuff. There's a lot of stuff that you could assess. So, but you got your SATAs. If you got a SATA, just you guys got it, right? You guys got it. This feels like a SATA question. Like it like makes itself almost. And maybe less so much about F and E, but your creatinine and GFR are more like kidney function, which can have an impact on your F and E, of course. But um, so I think we said urine output. Yeah, we said urine output. Yeah. But again, your creatinine GFR is more about your kidney function. So hopefully they don't throw that one in there, because that would confuse me too, honestly. If I got like technically it affects, but then maybe I'm building on the question. Remember, you don't want to add
Oh,
to the
bro.
question, but I don't know, man.
Don't even remind me. I don't want to think about that. I did that. I did that in 220. I'm still salty about it.
And then here, just dehydration versus FBO. We already talked a lot about it, so I'm just gonna copy paste the stuff that we talked about here. Pretty much all of this here is good. Paste. Oh, that looks weird. I'll fix it. Boom.
Are the levels of dehydration important to know?
The levels, no.
I was about to ask. I don't know exactly what you're referring to.
Why is it like this?
Why are you like this? I don't know. I can't tell you how to fix it because I'm horrible at technology.
That's better.
You fixed it. You got it. Got it.
Okay, you did it. Okay, and then we'll go ahead and pick up your
Your,
your.
your. Oh, I'm cracking my toes.
They want you to know mild, moderate, and severe. Who's they? Is that Orozco and Hively?
Oh,
Maybe there's
okay.
some Kaplan questions that might help with that.
I I have no idea. It was an assignment.
Maybe. Oh, it was an assignment? I guess just go off that.
I was like, I don't recall doing that when I was in 220, so that might be something new, but
Hmm.
I don't
Yeah, I would say if they told
remember.
you, I guess go ahead and make sure to review that. Yeah, I don't know it too well at the top of my head, if I'm being honest.
Give me.
Yeah, they are. I think we did have one. I think I remember being confused, and then we were like, I'm confused, and then they're like, I don't know, and then yeah, I don't know.
Oh, girl, I ain't know.
But yeah, um, good. Anything else we think we can add here between these? Yeah, so I guess Caleb been knowing the severe stuff right there. Look at that.
Sheesh.
Yeah, sheesh. All right. Anything else you guys think we can add for dehydration and FBO?
My sanity.
We did cover a lot. Maybe we can put pitting edema or cool pale skin. Cool pale skin, edema. What else we got? Maybe you can get shortness of breath, crackles in lungs. SOB crackles.
Crackly dacklies.
What else do we got? Maybe some headaches. Dry scaling skin, sunken eyes. Oh yeah. Dry skin, sunken eyes. That's usually a late sign.
Wings.
For dehydration, you probably won't have crackles. Let me see what else. What else do we have that might be hypovolemic?
For
uh,
dehydration.
Yeah, dehydration.
I like that one. Dry membranes and tongue.
Dry membranes.
You might have
Hypotension, decrease
increased
urine
respiratory
output.
rate.
Oh, I think it's already there now.
Is it? Da-da-da.
Weeping edema.
No.
Weeping edema is gross.
Furrows on the tongue. Ooh, I forgot about that one. That's yummy.
Yeah. You could have puffy eyes, weeping edema. Sure, I'll include those. Why not? Weeping
Have you all ever
eyes.
seen weeping edema?
Sorry, puffy eyes. I've seen it. It's gross.
I had a lot of patients in the care homes with it.
Orthopnea.
Ooh. Ooh.
Yeah,
She
come
pulled
on.
her out the stops.
Kind of just goes along with some of these.
I like it.
Picasso.
Exactly.
I think that's typically the main things for both of these. We can thready pulls. I think we'll go with that. Cool. So now we're down to the last little bit, and this should go a lot faster. So we'll probably end a little bit earlier, or we can ask some questions at the end, or whatever you guys want to talk about. Kind of just doing a general IB fluids and electrolytes. When you're giving an IB piggyback, what are some of the most important things you want to really think about? That's a good one. Sure. I'll put gravity, gravity and height. And we'll talk about, of course, your compatibility is a big one. See, I spelled it wrong. It's okay. I spelled it wrong too. Wait, it's what? My autocorrect spelled it wrong. Okay, whatever. Allergies, of course. Yes. The color of the expirations. Yeah. All that, all the classics. But yeah, compatibility is your number one. You want to make sure that it's compatible with your primary. So if they have like lactated ringers, it might not work. Yeah, you're good stuff. Your 5 rights, 3 checks as per usual. As per usual. And then obviously it's a medication, so you're checking to see, is it appropriate? Why are they getting it? Okay. And then I'll just do like a quickie on 3% normal saline. If you're given it, what do you kind of talked about it. It's for severe hyponatremia. So typically like under 125 sodium. But it's also a med, so you again would never give a med without the labs to prove it. So you can't just make assumptions. You can't just assume based on what they've been eating or not eating or what they've been having issues with that they're going to be hyponatremic. You need to have your labs to prove it. So just kind of keep that in mind. We don't just willy-nilly give someone 3% sodium or potassium without knowing that they need it. Okay. So just keep that in mind. Same thing here. So it's going to be for hypokalemia and check labs. Make sure patient needs it. Check labs. Okay. We don't make assumptions. Remember that. Okay. Just like how we don't go, oh, my hypertensive, my patient with a history of hypertension is going to have hypertension, so I'm not going to check the blood pressure, right? We don't do that with those, so we're not going to do that with your 3% NS. We're not going to do that with your potassium, okay? All right, we're almost done, guys. This is just general guidelines. This is like some 212 stuff, but just because it might help you in clinical. Does anyone remember how often you change the peripheral IVs? Even though, honestly, I think I've seen them just keep them the whole time, but they probably shouldn't. '96, 72. I think I've seen 72 to 96 hours, so 3 to 4 days. Okay. What about your primary IV line? How often should we change that? Your line, your primary IV line. Okay, there we go. So your line is 72 to 96 hours, and your bag is 24 hours. Okay, so let's say you have someone getting some IV fluids. Let's say you prepped a full bag or whatever, and you're running it, and it's running at a certain rate. It's gonna run out by the end of the day. But then the doctor lowers the rate down to a lower number, so now that bag is gonna go over 24 hours. Even though there's still fluid in the bag, you technically should change it after the 24 hours. Does that make sense? So let's say you prep a bag of NS and it's going to last the whole day, but then the doctor changes the rate to make it slower, and now it's going to go over the 24, even though you still have NS in that bag, you would replace it with a new one. Okay, so every 24 hours we replace the bags. Cool. And just remember to make sure things are labeled. That will be part of your CPE as well. Just like something you can say, be like, I would also label my line. So like after you prep your primary IV, you'd be like, I would also I would also label my bag. I would label my lines, so that everybody knows that this line is good for this amount of time, so they can reuse the line, and whatnot. Okay, so keep that in mind for your CPE. What's the PIV? That's the peripheral IV. Peripheral IV. What about your secondary IV line? How often do we change the secondary IV line? So this one, in theory, should be every 24 hours. Yeah, Jennifer, good job. And then the bag should also be, in theory, or this one should be in 24 hours as well. So, something I don't think they go over too much, but for your secondary IVs, you might have seen this in the room. You might have seen an empty secondary bag with the line. It's just hanging on the pole. And you might have wondered, why is that? Why did they do that? Why did they just leave it there? Has anyone seen that?
Huh?
I said, has anyone seen like a secondary IV line plus bag just hanging, like empty?
I have, but I don't think whatever reason you're about to say, I'm pretty sure this is not aligning with the reason that I saw it.
I was about you can reuse the line. That's what I was getting at. Is assuming it's within the time. So if someone has vancomycin twice a day or whatever.
Oh, you mean like just not, it's not like fully hanging off to the side.
No, I meant like it's attached to the pole still, but it's not hooked up to it's capped and it's not hooked up to the machine. But it's there, is what I mean.
I I would use a bit of caution on that personally, but to each their own.
I see. Well, has anyone seen that then? No? Okay. Well, I've seen it a lot, and that's just that the secondary IV, let's say it's someone's getting they're getting antibiotics, the same antibiotics, like every 12 hours. So what some people will do is after the secondary finishes infusing, they will disconnect it from the primary. They will cap it with, it's like one of these caps made for the secondary IV. They will cap it and they will leave it hanging on the pole. So that for the second dosage, because it's every 12 hours, the new nurse or the nurse will just unspike it, unspike the empty bag, spike the new bag, and then just connect it to the primary. Because your line is technically good for 24 hours, you can reuse that secondary IV line. You never seen that, Kaylin?
So here's what I was told about like if you walk in a room and you see like what you're explaining where there's a bag, you have the line and it's all kind of just on the pole, but it's not attached to the pump or anything. I was told if the bag's empty and it's just chilling there like that, you throw it because you don't know like what if it was already contaminated or like you don't know anything about this random bag just chilling there with a line in it. So I was told to throw it.
I see. We were told to just use it.
I think it depends on your instructor.
Might depend on policy. Different
Oh,
places might have
probably.
different policy. But I'm just saying that's something I've seen. And again, if you're going to Lakewood, you'll see it. I'm sure you'll see it. But yeah. Oh, see, and side, and she goes to Lakewood, so that's what I'm saying. Maybe Lakewood policy is that, or other
It might be.
reasons, or other reasons.
Oh,
But
wonderful.
yeah, that's a thing I saw a lot because I've gone to Lakewood 3 times. This is my third time going to third rotation at Lakewood. I say it all the time. Yeah, so that's just the thing. Okay. I don't think they test too hard on this for this quiz. I think it's more about your fluids, but it's just there because I think this could help you for your clinical and it can help you for your IVCPE, okay?
Fluids.
And then this, I guess we'll just talk it over. This is called this is a large bore. This is called a large bore. Good for fast infusions. Good for fast infusions, blood. And the same thing. Good for fast infusions and blood. If someone's veins are too fragile for an 18, you might give them a 20. But if someone needs potential blood transfusions, you'll want the 18 or the 20. If someone potentially needs as a high risk of some sort of thing where they need rapid IB to be pushed or a rapid IB bolus, then having the large bores is better. Then your 22 is your standard one. And 24 is usually for elder or children or those with smaller veins or weaker veins. And that's just kind of information for you. 18s are, does anyone know the colors for 18 gauge? Yeah, this one's green. Which one? Best for meds. They're all good for meds. They're all fine for meds. As long as this one's not going to be as good for like rapid infusion. But you can use meds for all of these can use meds. But these are going to be better for emergency situations, 18 and 20. Okay. What about 20 gauge? What color is that? That one's pink. And blue? Oh, bro. Whatever. I was gonna say N22, but I just said blue instead. Okay. Well, yeah, blue 22, and then 24 is what? Yellow. Cool.
Yeller.
Yellow. So we can now, towards the end, just the complications of IBs. I'm sure you guys got tested on this in 212. It might come back again. Just kind of know the general idea. You got your phlebitis and your thrombophlebitis. So what does that look like? How do you describe these? Sure, inflamed. How else would you describe it? Red cord-like, exactly. You'll have some warmth. Can be hard as well. Yep. Perfect. So if someone has this, how do you intervene it? What is your first action? Yep, DC the IV. And then you follow your policy for what to do after. So if your policy is to put cold or warm, it depends. But I think they told us cold compress. The theory being that the cold keeps if there is a potential cloud, it keeps it from moving. Okay. What about infiltration? How would you describe that? Mm-hmm. Sure. Leakage around the tissue is good. Yeah, they call it edematous. Edematous, which means it's edema-like. Yeah, perfect. And how do you treat this one? Or what do you do with this one? Again, you're DCing. You're seeing the pattern here. We DC. This one you can also elevate because with the infiltration, it's going to be with mostly with your primary fluids, your NS and stuff. So you can elevate. The idea is then it allows that fluid to drain into your system and kind of decreases the swelling. So think of it like a swollen, um, like a sprain or something. You can put elevation to get some of that blood to stop pooling. So elevating is good, and depending on your policy, either cold or hot, called cold or warm. I've heard warm a lot because the warm can help spread it around, but it depends on policy and stuff. But for sure, DCDIV, and you can put some elevation as well. So what about extravasation? How are we describing this? It's the we cool. Yeah, it's gonna be a burning, stinging, necrosis. It's gross. Blisters, yes. And this one again, wow, DCIV. And there's a few things that you could do. I've heard aspirate. You can potentially leave the IV on for a little bit. So maybe you could aspirate if possible, then DCIV. The idea would be you can aspirate maybe some of that stuff out. And yes, you want to call rapid response because then they can get extra hands on deck. They can get the antidote. Yeah, usually the RRTs are going to have the antidote. So potential for antidote if needed. Cool, cool, cool. And then hematoma. How would you describe that? Just kind of like, what do you guys think about hematoma? Hematoma. Looking like this. Maybe a little bit like that. Maybe a little bit like this. Yeah. So we said DC means holding it. DC means disconnect. So like disconnect the IV. Like literally pull it. Like pull that thing out. Get rid of the IV. Same thing with an infection. If it's infected, you get rid of the source, so get rid of it. Yeah, like bruising, blood leakage is a good one. You also see maybe like hard skin, like hardened red skin, for example, red purple skin. And with this one again, you want a DC, and I've been told to apply pressure. Yeah, exactly. Apply pressure and stop the bleeding. Perfect. And that's the main ones you guys really go over. Any questions on anything we talked about? Nice. We got through it in time. Perfect. It's a lot of content here. Hopefully this helps you guys for the quiz.
Wow.
Well, the only thing that kind of sucks is that it'll probably take a few days for you guys to get the results of the quiz.
Oh, I forgot about that.
But it's for the best because I think the reason it takes a little bit is just because, yeah, just because I think they review it and they'll see what people are getting wrong and maybe they make changes or not. Depends. So I think that's the reason why they take longer. It's just because they're reviewing to see if there's no anomalies in the questions. Like no weird question where like everybody gets wrong, for example. Kind of vibe. All right. So how do you guys feel? Feel okay? Feel scared? Nervous? Fair, fair, fair.
It'll be okay.
Fair, fair, fair. But yeah, I think you guys would be able to do it. You get barely. Yeah, I saw your guys' your points breakdown. You guys get 6 points. That is not exams and quizzes, and the rest is exams and quizzes.
6 points?
Yeah, they get 6 points from discussion boards, and
Ugh.
then the rest is all exam and quizzes.
Bruh.
Yep. You have a total of 176 points. You guys can miss 44 points to still pass. So think of it like that. Yeah, it is. What even worse?
What?
Okay, guys. I think the student center closes soonish. I wonder what happens
It
if we stay
closes at 3.
3. I wonder what happens if we stay longer. Like, do they just like close it? I think they do, huh? Because
I
this
don't know. I've actually never had an instance like this, so I
it's
don't know.
technically a breakout room. Just in case, like, there's a chance that we go over. Would you guys ever be okay at starting 12:30 instead of 1? How do you guys feel about that? Would that be
Wait, did
okay?
you, just in case, did you put this into the chat?
What? Put what into the chat? Oh,
Uh, Do it
Okay.
now.
Yeah.
Do it now.
Okay,
Hey
hold on.
guys, I'm just letting you know we close in 1 minute.
Yeah. Sorry. I got it. Hold on.
Leave and achieve. You
Ah,
can do it.
ah,
I told you.
ah.
Why didn't you do it sooner?
I forgot. Ah, wait. Chill.
Bro, I'm getting anxious and it's not even for me.
All right. There you guys go. Download. If any of you didn't download it, just message
Tell
me
your
on
friend.
Pronto.
Phone a friend.
Message me on Pronto. I'll get you.
Phone a friend. Hurricane Tortilla.
So you guys are cool with starting maybe next week at 12:30 instead of 1, just in case, so we don't have this problem, just in case. All right, cool.